We have a select audience this afternoon for a very exciting topic. But I would ask you, when you ask questions, we'll pass a microphone around, because every week there are between 200 and 400 people who are sitting at their computers, or maybe today sitting with their computers out under a tree in the sunshine, and they regularly attend the course. So you are speaking. Furthermore, after the second day, all of what you say and your image goes out to the world through the NIH Video Archive, where it's downloaded now, and we're up to 19 different countries and over 24 major North American institutions. So normally we show a picture, a photograph that my grandfather took back in the 19th century, but we have a little logistical problems and they can't find it today. But it's a photograph of the Brooklyn Bridge, and it shows New York on one side, Brooklyn on the other, and two gentlemen sitting on the middle of the catwalk, which preceded the roadway, so people could actually walk across on this thing. And the reason for it is that's the logo for the idea of demystifying medicine, mainly for PhD students, because we're all sitting on that catwalk between knowing some things about medicine and disease and clinical stuff, and the others about molecules and so-called basic science. And what's missing is communication. So this is basically a course in communication. And communication is only worthwhile if you have questions, if you ask them. If you don't ask them, there's very little communication. So the speakers who will be talking about areas that maybe are not familiar to you, you shouldn't hesitate to raise your hand and speak up, and that makes it, more interesting. Now, in thinking about today's topic, uveitis, this is a real serious problem, and a very common problem, and something that has sort of been kind of, I think, in the broad aspect of medicine, somewhat been left alone. It's sort of for the ophthalmologists. Now, what's happened, of course, is the ophthalmologists have also crossed the bridge into basic science and now look upon ophthalmological diseases as a manifestation of deeper-seated, bigger biological processes. And what I'm driving at is that throughout the course this year, one of the common themes has been inflammation. And so we've heard experts discuss and patients present various forms of inflammation and the way in which the body responds through the innate immune system, the adaptive immune system, toxins, the whole 9 yards, and also in the chronic sense of fibrosis, which was the topic two weeks ago. Now, many of those diseases that were mentioned and discussed occur in organs where there's a lot of space. So, for example, you can have a lot of fibrosis in the liver and you would never know it. But in the eye, that's a different situation entirely, because the intricate nature of the structure of the eye and its complexity means that inflammation in any part of the eye is bound to have some consequences functionally. Maybe it's pain, maybe you can't see right, maybe you see spots, maybe it hurts, maybe it's red, maybe it's hot, but it's all taking place in a small area. And so that becomes very significant, because that kind of inflammation can spread and lead to the real hazard of the whole business is blindness. And that's the problem. So I was fascinated in reading more about uveitis, to come up with a list of diseases associated with it, which I didn't know, and maybe many of you do know, but it brought to mind the basis of today's discussion. So that includes everything from AIDS, ankylosing spondylitis, herpes, zoster infection, histoplasmosis, toxoplasmosis, multiple sclerosis, rheumatoid arthritis. Does this begin to sound familiar? Syphilis, tuberculosis, ulcerative colitis, et cetera, et cetera. So when you think about that, and then you think about this inflammatory process in the eye, I hope you're thinking about what you heard previously about what is the pathogenesis of many of those diseases when they're discussed. So we're very fortunate today to have two experts discuss this. And the first is Sapna Gangaputra, who went to medical school in India and has a master's of public health at Johns Hopkins. She's a fellow in the Laboratory of Immunology in the Eye Institute. She had a residency in ophthalmology and particularly ocular immunology. That was at the University of Wisconsin. And she came to NIH, where she is a fellow and completed her fellowship in July of 2000, and you will complete it.
I will complete.
Yeah. And she has extensive experience with one of the great tools that's made ophthalmology so exciting, and that's retinal imaging. And so Sapna is going to begin, and thank you very much.
Thank you.
Oh, I should introduce also our second speaker so that we can proceed smoothly. So our second speaker is Mary Mattapallil. She went to veterinary school initially in India and then graduated from Nehru University with a PhD in molecular genetics, and then got interested in bioinformatics, where she had a graduate certificate at the University of Maryland, came here as a postdoc in the Eye Institute, and currently is a staff scientist in the immunology branch of the Institute. Now, her work is extremely well known and very exciting, dealing with genetic factors involved in the regulation of autoimmunity, a common theme in some of those uveitis producing diseases. So we're grateful to both of you, and please begin.
Thank you. Thank you all so much. It is a pleasure to be here. Does my voice carry to the back? Good, great. Since most of you are here, so I'm going to stand a little bit this side. I'm going to start with a disclaimer. I tend to speak fast, especially when I get happy and excited. So stop me and I will slow down. Okay. I'm going to start talking about uveitis. And this is mostly an autoimmune mediated disease. What I want to highlight today is the layers of the eye that are affected by uveitis. And like every other sphere of medicine, even in ophthalmology, though it's one small eyeball, we have multiple subspecialties within ophthalmology, which people say, well, how much can you fight in that little space? Well, we do, and we manage to succeed too. So uveitis affects the iris, which is the colored portion of your eye, brown, gray, hazel, brown, black. And then this is the ciliary body. The ciliary body has muscles that help your lens to expand and contract, that helps with accommodation, so the ciliary body. And then it goes back to what we call a small area called the pars plana, and then the uveal tissue lines all the way to the back, the choroid, the vascular supply to the eye. So these are the layers that predominantly, when affected, it comes under the generic term uveitis. Even though, like I said, we say that we are important, but uveitis causes visual impairment in 15% of people. The leading causes of blindness today in the young population is diabetes, among older people, macular degeneration, glaucoma, and then uveitis. But when it hits hard. Visual impairment is severe and comes on very strong. And then most of this is irreversible blindness, so it becomes really problematic to treat. Most of uveitis is non-infectious, but it can also be caused by infectious etiologies. As Dr. Arias just mentioned, it can be viral, it can be bacterial, it can be parasites. And I will talk to you some more about these as we go on. But predominantly, the one we're going to focus on today is autoimmune uveitis, which is mediated by CD4, Th1 T cells. And my colleague Mary will be talking to you much more about this in the near future. So I did mention this to you. It affects certain portions of the eye, but in order for us to be more standardized in what we call uveitis, a group of uveitis experts from around the world met and decided to standardize the classification, because what in India we called, for example, vasculitis was called parsplanitis here. And so even though there are few patients, reporting being non-standardized makes it even harder for us all to know what the other person is referring to. So they decided that the one way to classify uveitis would be by location. Where is the predominant location of inflammation? And that's how we're going to call it. So if it affects the front portion of the eye, the iris, we'll call it iritis. If it affects the iris and the ciliary body, we'll call it iridocyclitis, and so on and so forth, to be more standardized across all countries. When it affects all three layers, it's called pan-uveitis. The prevalence of uveitis has been studied in some broad population-based studies. And as you can see here, it's really, even looking just at my red arrows, which points to Rochester in 1954, and they had an incidence of 17 per 100,000 persons per year. And then Northern California, 50 years later, 52. Does that mean the incidence has increased in 50 years? I think it's more because uveitis gets lost in the crowd. Uveitis people present with red eyes. They get treated as conjunctivitis. They get treated as dry eye. Many inflammations don't get treated at all. And so I think this is just a bias of reporting. This is a busy slide, but what I want you to take home from this is that recently from Johns Hopkins, they looked at the prevalence of uveitis using claim-based, meaning insurance-based. So it's not truly population-based. This is people who have that certain insurance and saw the doctors who fell under this umbrella and what they billed them as. But what came out of it was that uveitis affects women more commonly. We knew that before, but this reinforced that it also is more likely to be non-infectious. Almost 91% of times it's non-infectious. The infectious etiologies cause a smaller portion of it. And when it does affect the eye, it's more commonly going to affect the front portion of the eye versus the back portion, which causes the debilitating blindness. So all good stuff. How do we grade it, or how do we test or know? So when someone comes to me, how do I know that they have uveitis? So again, the committee that I spoke to you about, which wanted to standardize it, so it's called the Standardization of Uveitis Nomenclature. They define certain criteria in order for us to be able to assess a patient in a standardized manner. So when we report the disease in a standardized manner, we assess the disease in a standardized manner, and then we look at outcomes in a standardized manner. So this study really, in 2005, it wasn't all that long ago, and this study really revolutionized how uveitis papers are being written today. So here I'm going to point, just so you can orient yourself. The dark iris is a brown iris, and then the front portion, which you can't see really well, imagine if you had a clock. This is your watch. There's a flat face where the numbers are, and then there's a clear round glass through which you look through and see that. So the clear round glass is your cornea, the front portion of the eye, which is transparent, and light then goes through that. The pupil, or the central opening of the eye, in this case is really enlarged and wide because we dilated this person. But between the plane of the iris, the flat brown iris plane, and the hemispherical clear cornea, there is a space. And that space is where the aqueous humor lives, or the anterior chamber of the eye. So when there's inflammation in this front portion of the eye, you see inflammatory cells. So we have the standardized method of testing where we take a slit lamp, which is has anyone had an eye examination? Then you know what a slit lamp is. It's that cool instrument that you sit at, rest your chin, and the doctor looks at your eyes. So that one shines a bright beam of light at an angle in, and what it does is you see those dots lighting up? So it lights up all the inflammatory cells. And believe it or not, we count those inflammatory cells. So we count, now I don't, if it's a lot of cells, I would just say this is 2 plus or 3 plus. We'd round it up. But basically, this is the standard procedure that you use to assess how much of inflammation there is in the front of the eye. The second thing that they agreed upon is how to assess inflammation in the posterior portion of the eye. So here, if, again, you've been to an eye doctor, your eye doctor's looked inside your eye, what they've seen is something like this. I'm going to bring your attention to the top image there. So you see the yellowish disc, that's your retina. When someone looks in the back of your eye, when you take photos, sometimes you have a red reflex. Your eye looks red and the center of the pupil looks red. That's because your retina reflects red light or orangish red light. So that yellow is the retina, and the center yellow disc is the optic nerve. The way I explain it to my patients is I say, this is the cable that connects your nerve to your brain. It carries information from your nerve, from your eyeball to your brain. So that's the nerve, and it's like a tube. And through that tube run your blood vessels. So you can see those red lines coming up. Those are the blood vessels that supply the retina of the eye. So this is something, if you looked into a normal person's eye who didn't have a cataract, didn't have any scar in the front of the eye, that's how you would see it look. And so what this group of people did was they took a series of photos and they said, how clearly can you see in the back? Because if you can see very clearly to the back, that means there's no interference, there's no inflammation in the eye. So that shows you just about a clear image. And as you can see all the way here, there's so much of inflammation in the eye that you can barely make out the details. So we use these are photographic standards. So we see the patient, we compare it to photographic standards to see how much of inflammation there is in the eye. We use that guide also to help us to assess how much inflammation there are. This again here is a normal photo. Again, the right eye. This is now, we've made a lot of progress with retinal imaging or photos that we take of the eye. And so this again, I'm just going to point out the nerve because now it looks nice in yellow color. You can see the nerve, blood vessels coming out of it. And this other little darker area that you see in the middle, that's the area macula, or the area from which you see, the area that has the largest concentration of cones. Or in med school, I think in high school, we called it the yellow spot. Have you heard of that? No? And this one here is a fluorescein angiogram. This is one of the diagnostic testing that we do to study the eye. So how do we do this? We first inject a vegetable dye into the patient's veins. This then travels. It's almost, I explain it to my patients like this. I tell them, you have an orchard and you want to see how much of it is getting water. So you pour buckets and buckets of water down your stream, and pink water. And then as the water reaches there, if the leaves start turning pink, you're stretching your imagination, I know, but I think it conveys the point. So as the leaves turn pink, you know that that pink water has reached your tree. So similarly, we do it here. So we inject a yellow colored dye. Sorry. We inject a yellow colored dye. That dye then comes in and fills up your vascular tree. And everywhere that the dye can reach shows you where the blood, how the blood would flow. And so we'd be able to study the vasculature of the eye. We take pictures as soon as we do the dye, a little late and then very late, to see how the dye comes in through the arteries, goes through the capillaries, veins, and then washes out. So we can actually study the flow of blood in the eye. These are two other forms of imaging in the eye that we are using more and more frequently. I want to show you what we do upfront, because when I show you disease states, then you know what we're looking at. And we can come back to reference this if needed and if we have time. So on the far right, it looks like a black and white picture of the fundus. But what it is, it's called autofluorescence. Remember I told you, we put fluorescein dye and we take pictures. But some structures of the eye, specifically lipofuscin, it emits fluorescence even without dye. So we can then take pictures of the eye before we put the dye in, and then if anything is emitting light or fluorescence, then we know what that structure is. We also use it to see healthy versus unhealthy retina. So dark areas that we see, if we would see a black area, We know that there is no RPE there. The retinal pigment epithelium is gone and we're seeing right through it. So we know that that's dead tissue. If we see a lot of brightness, we know that that is sick tissue. So we use that to categorize sick from healthy and dead tissue. And on the right side is called an OCT, optical coherence tomography. This is one of the cooler, newer advances that we have. And again, the way I would want you to understand this is, imagine if you was lying on your back, and then I was to take a cross-section of your eye. So this shows you the inner layers of the eye in cross-section. It is all physical properties. So light comes in, and then it reflects back. It's pretty complex physics that I don't quite get, but what I get of it is that light comes in, reflects back by different strengths based on the density of the tissues it's passing. So tissues that are denser, thicker, like the retinal pigment epithelium, comes with brighter lights. Areas that have less, have only cells, don't have real melanin or anything in them, you have lesser tissues to bounce back, you have a lighter signal. If there was fluid, that you'll see darkness, blackness. So this is the inside of the eye, the jelly of the eye, and this is the outside of the eye. So this is one of the structures that can show us not just structure, but actually cross-sectional layers of the retina of the eye. Do we have any questions still here? Okay, good. And thank you for stopping me when I went too fast. So two of the functional testings that we do for the eye, one is called the visual field test. And I think a simple way of trying to explain this is they define it as a hill of vision in an island. So if I was standing really close to you and I held up a small, bright, shiny light, you would see it. But if I went all the way outside and held up a small, shiny, bright light, you wouldn't see it. But you would see it if the light was very big. So this is how we try to test your visual field. So we try to move objects, a small object, and then we try to assess where can the person see it best. And as these lines show you, the further out you go, unless the light is brighter or bigger, you won't see it. And then the central area that you see in the dark is your blind spot. This here is called an electroretinogram. This is like when we were in school, high school, and we made those electrical circuits, and when you connected it, your lights came on. It's pretty similar to that in the retina of the eye. When light falls on your eye, that gets converted to an electrical impulse. This electrical impulse then carries to your brain. So we can objectively measure the functioning of the retina by placing electrodes on the eye and then measuring that electrical impulse. So this is what it does. It measures electrical impulse through different layers of the eye. So let's get some pictures. Don't have any gory pictures, so don't worry. So anterior uveitis, like the name suggested, affects the front portion of the eye. So if you look at the back of the eye, the retina looks really clear. You're not seeing any lesions. This is a fluorescein angiogram that I spoke to you about. It shows you normal vasculature. You're not seeing anything abnormal in the back of the eye. All of the pathology is in the front of the eye. You can already see that there's a little layer of like a white boat-shaped substance here. So this is inflammatory cells that would spill out and then collect at the bottom of the eye. We call this a hypopyon. But basically, all of the inflammation is in the front of the eye. These brown dots are when the eye, there's a lot of inflammation in the eye, the iris tends to scar down to the lens. And when we put drops to dilate his eye like we did, it breaks away. So this is iris pigment that got left behind. We call that posterior synechia. These patients have acute symptoms. They complain of pain. They complain of severe redness, vision disturbances. They'll say their head is paining. Their head is going to explode. And typically, the most common time we see this is associated with HLA-B27. And unfortunately, for young children who have juvenile rheumatoid arthritis, is the most common presentation. And in those young children, 4 or 5-year-old children, they don't even complain of pain. So we have to see them to know that they have inflammation. So we screen those children even without eye symptoms to look for inflammation in the eye, because it can lead to severe sequelae, including cataract and glaucoma. Here's some more pictures of the front of the eye. And as you can see over there, last time I showed you that little boat-shaped thing where the cells went and settled down in the bottom with gravity, but it can also coat the front surface of the eye. We call that keratic precipitates. Based on how it looks, it helps us to classify if they're fine and thin, like this, just fine dots. Those can be herpetic. Herpetic can have just fine, dotty keratic precipitates. But when you see them big like that, that's called mutton fat keratic precipitates. That is a sign of granulomatous inflammation in the eye. Typically can be seen with something like sarcoidosis, tuberculosis commonly. Here what I wanted to show you was, you can see even the iris has a few nodules. These are inflammatory nodules on the iris. And here's the cornea. You can also see inflammation on the cornea. These are all really great pictures taken by our photography department, where they know to focus in on exactly what pathology we're trying to look at. The picture on the top right is just pigment. That's someone who had a lot of inflammation, and then all of that inflammation has now subsided, but it left residues behind. So it leaves its footprints behind for us to know that this was an eye that had suffered in the past. So it's outside the eye. It's in the front of the eye. It's accessible to eye drops. So if there's no inflammation in the back of the eye, we can treat with eye drops. We can also treat them, if needed, with steroid injections right around the eye. So deliver steroid right to the eye. Steroids, inflammation is very sensitive to steroid. Most people can get treated with steroid drops alone. I'm not going much into the pharmacology of it, but there are milder steroid drops and there are very strong steroid drops. And we choose one based on how the patient presents and try to taper it down as per the patient can tolerate and as the inflammation subsides. But there are some people who the inflammation never goes away and drops are just not enough. For example, we start the person on, say, 4 drops a day, and then we go down to 3, and the inflammation comes back. So we go back to 4 or 6 times, come down to 2 times a day, inflammation comes back. So people whom we are unable to take off the drops, they need something more. Then we're talking about giving them oral steroids. So we either give them oral steroids, and if we're on oral steroids for a while, especially if it's a younger child, then the better option would be to switch them to a steroid-sparing agent or immunosuppressive agents. I'll talk a little bit about this towards the end of my talk. And these are just examples showing you the synechia, or the scars, which bind the iris down. And there you can see there's already a lot of vascularization happening as well. You can see the big, juicy iris blood vessel up there, which normally we don't see. And under that, the lens, which should have been clear, is looking white in color because now it's formed a cataract. So go to the next layer, intermediate uveitis. So that schematic can tell you that what intermediate uveitis is. It's that middle layer, and all of this inflammatory cells then collect more so inferiorly because of gravity in those middle layers of the eye, and the jelly in the eye, the vitreous jelly of the eye, becomes granular. So these patients complain of floaters. They say, I see a fly and I'm swatting at this fly, and the fly just won't go away. The most common cause of decreased vision in these patients, apart from the annoyance of the floaters, is, remember I showed you a picture of the OCT, which was that nice hourglass-shaped picture, but here you see there are big cystic spaces in the retina. That shows that there's fluid accumulating in the inner layers of the retina. And here too, we call this subretinal fluid. It's under the retina, so subretinal fluid. And so this fluid accumulates. This is a fluorescein angiogram. I showed you a picture of how a fluorescein angiogram happens. And so these layers of the retina are sort of like petaloid. So the layers come together at a point. And so when fluid accumulates in them, you see them as these lovely little petals of a flower, like a daisy. So this is known as cystoid macular edema. New researchers of the standardization of uveitis nomenclature that I spoke to you about, they choose to not call this inflammatory, but a structural change because of inflammation. You say the semantics, but what I'm trying to say is these patients, we could treat their inflammation. Their inflammation could be all gone, but this damage could still remain and persist and cause visual deficit in these patients. So here's some other examples. It's called snowballs and snowbanks. Someone's going to back up here. You see how it collects like a snowbank? We got some snow this year. So snowbanks. I'm from Wisconsin, so for me this was not much snow at all. And when there are clumps of inflammatory cells in the vitreous, we call those snowballs. So here's a picture on the top, if you can see, where you can see collections of inflammatory cells. Those are snowballs. Same here. Collections of inflammatory cells. This is a montage. That is, we take many pictures of the eye, and then we piece it together like a quilt so that we can see a larger area. And here is a cross-section. It's really difficult to see what you're really looking at, but if you back up a little bit in your mind about the previous picture I showed you, the iris, the cornea, and now we're shining the light a little behind the lens. This is the lens. So we're going behind, and you can see the vitreous has all these like curtains and veils, which is what the patient also notices and sees. So all of these are signs of inflammation in the vitreous. I put in there, don't forget lymphoma, because that is one of the biggest signs. When lymphoma, we see these patients, it's called masquerade for a reason. These patients present with inflammation, we give them steroids, they get better, take the steroids off, they get inflammation again, and we keep on treating, and then eventually we realize that they have lymphoma. And the only way to diagnose lymphoma is by taking a little vitreous fluid from the eye and testing it. I'm going to take a minute to breathe and also ask you if you have questions. Don't?
So some of the edema of the macula is from diabetes also. So
Sure.
This is a non-infectious edema.
Right. So is diabetes. It's non-infectious too. But it's the same pathology where there's exudation of fluid causing fluid collection beneath the retina. It's also seen in vein occlusions.
So at what level I should worry about? I'm diabetic. So
If your blood sugar is well controlled and you have no vision problems, I think you should be okay. And you get your frequent eye examinations. So I talked to you a little bit about we can treat with drops or we can treat with steroid injections because the swelling is a little bit more behind the eye and it's easier for us to treat with steroid injections because otherwise the drops can only penetrate so much. So I didn't want to put, again, I tried my best not to put graphic images that can frighten you, but we push the eyeball up and just go right below here to inject the steroid. So it leaves a depot of steroid right behind the eye. We can also go in what I call the skin of the eye. So the eyeball has multiple layers, and so we can go between some of the layers of the eyeball. So we're not penetrating inside the eyeball, but surrounding the eyeball and delivering steroid. We can also go inside the eye. So this is, I put this here, so you know that's the only brand name that we have, so I had to put a brand name up there, I'm sorry. But here we can inject, it's a small little pellet, and this then slowly releases steroid into the vitreous. So we actually inject it into the eye, and then it releases steroid for this lasts about 4 to 6 months. There's another company which produces another steroid implant that releases it for up to 3 years. But that needs to be implanted by a surgeon. So you have to cut down the eye and put it in. This we do in clinic.
what is the word IMT?
In immunosuppressive therapy. So if people don't respond to steroid, and if you need a lot of steroid has a lot of side effects. There's mood swings. People have really bad mood swings. Some people can't sleep. Some people get depressed. Weight gain is a problem. Your whole pituitary axis gets depressed. Osteoporosis is a problem. And so there's a lot of side effects of oral steroid. And so if we cannot keep someone on oral steroid for too long, especially if they're diabetic, then it'll be a real problem. And so we want to take them off of it and put them on immunosuppressive agents, which are cancer drugs that we call cancer drugs, like cyclosporin, methotrexate, medications that can then help us to take the steroid off. So let's talk a little bit about, we're going a little behind posterior, that's affecting the choroid and then affecting the entire eye. This can present in multiple ways, and I have several pictures coming up. Also, it's very frequently affected with systemic disease. Specifically, I put in a few names here, but there are many, many more systemic diseases. Infectious diseases are common. Tuberculosis, toxoplasmosis, viral infections can cause this. But about 30%, we never find out what caused it, and it's completely idiopathic. So these patients need more extensive workup. We not only have to do imaging on them, we also have to get blood work on them. Many a time we're doing CTs and MRIs. We are working with their primary. If it's IBS-like symptoms, we're working with GI. If it's infectious, we're working with infectious disease people. We're working with rheumatologists. We work with a number of other cross specialties to try to take care of this person not just an eyeball.
So in TB, what part of the eye gets infected?
TB, everything can get in, right from the front portion of the eye to the entire eye can get affected. We don't see as much TB here as we see in other countries, so it's still a pretty huge problem in other countries. So I put some examples of pictures because ophthalmology in general and uveitis specifically is a very visual disease. It's a lot of pattern recognition to be able to identify this. But I thought also it would give you a picture of how variable the phenotype is or how different it can look. How many of you have heard of toxoplasmosis? Say pregnant women don't touch the litter box. Yeah. So this cats carry toxoplasmosis, and it's then transmitted even through undercooked meat and water. A cyst can remain dormant for many, many years, but when it changes to the tachyzoid form, that's the active form that then causes infection. We many a time see young people who have these because they had congenital toxoplasmosis that's not affecting them, so we just ignore it then. This is an example on the top, is an example of an old scar. So you can see right there, when it's active, it causes retinitis, meaning it causes inflammation of the entire retina and causes it to look very swollen like this with overlying vitreous inflammation. But when that inflammation dies down, either by treatment or self-resolving, then it leaves behind a big scar. Now, this person was unlucky in that that scar is right at his macula, meaning it does affect his visual acuity, and that person will have really poor vision in his, this is his left eye. This right eye is also going to end up not being so happy. And toxoplasmosis tends to occur, it's like a satellite that happens right next to a pre-existing scar. So it's hard to see here, but there's a little darker area here where there was an old scar, and then a new inflammation comes right beside it. This is a clinical diagnosis. You can do toxoplasmosis serology, but most people are positive for especially if you're coming from another country. Toxoplasmosis IgG is present almost everywhere, but it's a clinical diagnosis, and it responds really well to antibacterial, antibiotic treatment. And so Bactrim is what we use, but there's other modalities. We can also inject, for example, clindamycin into the eye for someone who's intolerant of sulfur drugs. And even though it doesn't make sense, but there's the infection, and then there's the inflammation because of the infection. So we treat the infection, and then we also give the person steroid to help counter the inflammatory effect of that. Sarcoidosis is pretty common. Has anyone heard of sarcoidosis? So it can affect lungs. That's the one we most commonly talk about, is when you affect the lungs. You have this typical hilar lymphadenopathy. You do a gallium scan, and you have the panda sign. All of these things you would have heard of. But it affects the eyes. It can affect, it's granulomatous inflammation, can affect from the, you can see the conjunctiva, and it causes these granulomas, the giant cells, Langhans giant cells that, I'll use the pointer for this one because I'm not tall enough. So there is a giant cell. Here is a giant cell. So these are giant cells which you see with inflammation, granulomatous inflammation. And you can see here, you can see there's those granules. And this is one of my patients where you can see that he had inflammation all along his blood vessels with these clumps of inflammation. These are quite hard to treat. We don't even try with drops with them because they need systemic treatment. It's a systemic disease. So we put them on steroids. If they don't do well with steroids in a few months, then they ask for meaning they require immunosuppressive therapy to help manage them long term.
What type of cells are these? Are they microglia, macrophage?
Macrophages.
M1.
VKH or Vogt Koyanagi Harada is another common systemic disease that we see with uveitis. It affects people of pigment. So we see it's a lot out of Japan, but we also see people from the Middle East, Hispanics in America, Asians like me. Anyone who's brown color is at risk of having VKH. It has very typical clinical features where we call this, you see around his eye, there's whiter areas. Called periocular vitiligo. So that's that. You can also have, you can see this person, this was drug induced, but it's VKH. I put it there to show you because it's dramatic that when they develop VKH, his hair, within a few months, his hair turned all white, eyebrows white, eyelashes white, all of your pigmentation. You start losing pigmentation in this disease.
So what was the word VKH?
Vogt Koyanagi Harada. I can write it down for you later, sorry. And so this person, they present in the eye with, you can see here, it looks whitish, yellowish, and abnormal in color. That's because if you were to do a cross-section through here, you would see there's multiple pockets of fluid in there. And here too, you can see that there's an area, this is the fluorescein angiogram, and you can see all these pockets of fluid. So this causes subretinal fluid, exudative retinal detachments in both eyes. Again, needs extensive treatment with steroids, very responsive to steroids, and when it doesn't respond to steroids, then it needs immunosuppressive treatment. Behçet's, again, a disease that's more common out of Asia than here, also very common in Turkey. I have not seen even one patient with Behçet's, but my boss, Dr. Shen, who's not here, she trained in Turkey, and she said they used to have a specific Behçet's clinic because they saw so many patients with Behçet's. So it can affect both eyes, typically affects young males, and its very classic features are, you can see this hypopion, you can see that, and it causes inflammation of the blood vessels. So over here you can see that the blood vessels, which should have been red in color, now it's looking white in color because there's so much exudate that it's cuffing the blood vessel like a sleeve. It's literally cuffing it. And when we do a fluorescein angiogram, you can see if the blood vessel was normal and healthy, then the dye would just pass through it. But here, because it's an inflamed blood vessel, there's more pores. And so you can see that it's all fuzzy because the dye is leaking through the walls of the blood vessel. And so it makes the blood vessels look not sharp or clear. So this is called leakage or retinal vasculitis, inflammation of the blood vessels of the retina, inflammation of the retinal blood vessels. This is a pretty dangerous disease. People can die because it also causes cerebral vasculitis and also can get blind really fast. And so this needs very aggressive management. I grouped viral retinitis together, but viral retinitis comes in 3 flavors, so to speak. Basically can be caused by, this one is caused by CMV, cytomegalovirus retinitis, and in our teaching, we call it pizza because it looks like cheese and tomato ketchup, but it's a wedge of large amount of exudate and blood. So this is CMV retinitis. Here you can see what I meant by the cuffing. By so much of exudation, you can see a cuffing around this blood vessel. This is a different kind of viral retinitis caused more by the herpes virus called acute retinal necrosis. As the name suggests, it's acute and it causes necrosis of the retina. So it starts and then it rapidly progresses within a duration of hours. The entire retina can get necrotic and people can lose vision within a day. So this is pretty dramatic and requires us to immediately treat these patients when we see them. There are not very many emergencies for us, and this is one of them. This is another disease called posterior outer retinal necrosis. And as the name suggests, it happens in the posterior pole. So even though it's in the back of the eye, so because the eyeball is like this, it's the posterior pole of the eye. And it causes outer retina, the outside layers of the retina get necrotic, whereas over here, all 3 layers, all of the entire retina gets necrotic. But this one, even though it's not as aggressive as this one, because it is in a dangerous portion of the eye where it's so close to our macula and our optic nerve, this one also can cause very swift and very permanent loss of vision because it can snuff out the blood vessels effect on this nerve and the macula, causing vision loss. I'm going to close up.
And the red color is from the
blood.
RPE or from the red cell?
This one? This? It's blood. It's blood. So pickiness is another disease which looks like a serpent, very aggressive, causes you to lose vision really fast because it occupies this. This is a relentless, needs very severe treatment. Birdshot, as the name suggests, it looks like someone, I don't hunt, so I don't know, but apparently when you shoot, apparently birdshot splatters all over. So that's why it looks like this. You see lesions all over the retina. This is in the choroid. It's a choroidal inflammation, needs treatment. The workup that we do for any patient with uveitis is pretty extensive, not only just their testing to find out what the cause is, but sometimes we also need to do more extensive testing, because if we were to put these patients on immunosuppressive agents, puts them at risk of opportunistic infections. So we need to know baseline status before we start them on any treatment. We mentioned this, I'm just going to go over this last portion. Immunosuppressive treatment does not cure it, only is able to suppress it, but it counters the side effects of steroid, and it's better tolerated in that sense.
So if you take steroids orally, how much go into the eye? What percentage? 1%, 0.1%?
I don't know the exact, I know that there are papers about it. I don't know that, but I know that it is a fair amount of it, more than 1%. I don't know how much. I'm sorry. Yes, sir. He's behind you.
Oh, thank you. Thanks. Thanks for the talk. Just one question. What happened with the intraocular pressure? I mean, can you differentiate which compartment of the eye, or even what is the cause of the uveitis based on the intraocular pressure?
Sometimes, not always. Typically, uveitis reduces intraocular pressure. There are few conditions in which intraocular pressure is elevated because of uveitis, but by and large, uveitis causes it to go down because it causes ciliary body shutdown. But viral infections can cause it to go up.
Maybe I can ask a question. How do these various infectious agents get into the eye selectively?
They're systemic infections most of the time, but she'll talk to you more about the immune privilege of the eye.
Are there any other questions? Okay, if not, thank you very, very much. And we will have time after Mary's talk. Thank you.
Thank you all for coming. And now I will take over the research that is done in animal models. It so happened that my background is veterinary science, but I'm not a specialist in laboratory animals. So Sapna introduced to you the clinical symptoms of uveitis, and what is the mechanism of a uveitis. This is what we are studying using animal models. Of course, none of any single animal model can reflect completely or cannot mimic the human disease, but we learn from different models of uveitis what is happening in different diseases of a human uveitis. As Dr. Arias explained earlier, there are multiple different uveitic diseases, and each one has a unique symptom and unique pathogenesis. Since none of the animal model reflect exactly what's going on in the human, we try to study what are the similarities with the human disease and what are the differences with the human disease using the animal model. So we have all learned that eye is an outpocketing of the brain. But in evolution, you can see that jellyfish and scallop, which do not have a well-developed brain, but they do have a well-developed eye. So if you can look into the jellyfish eye, there is a well-developed structures of the eye. Same thing in the scallop. That is before an actual brain is developed. In the mouse, you have the similar well-developed eye structures, just like what we have in scallop and jellyfish.
So where in the jellyfish the eyes are? Location, point?
Well, I think it's on the forehead, but this picture is from the Monterey Aquarium. We can find out more from the internet.
Your Pianagorski's work and book, The Eyes of the Jelly.
So So there is evolutionarily a selective pressure to keep the vision intact so that we can escape from the prey or dangers. So there is always a selective pressure. And therefore, evolutionarily, it is important for us to keep our vision very clear, the pathway of the light very clear. And so the body has developed strategies to limit the inflammation. Clinically, we can see that there is some kind of immune privilege to protect the eye from any kind of inflammatory attack or immunological response. That this is one area where you can see the graft is tolerated for a long time, even when it is from an allograft. So there are three separate mechanisms for this immune privilege in the eye. One is actual physical separation, that is called the blood-retinal barrier. So here, the vascular endothelial cells are intact. It's not fenestrated just like any other place where the endothelium is fenestrated. There are holes in the blood vessels. And also there is retinal pigment epithelial cells that are tightly packed. It has tight junctions. So these two cells, the vascular endothelial cells and the retinal pigment epithelial cells, provides a barrier between the blood circulation and the retina. There is a local immune privilege or local secretory molecules that are present in the local environment of the eye that provides an immunosuppression. And also there is an eye-driven systemic regulatory mechanism. This is a crosstalk between the eye and the spleen, where cells are trafficking between the eye and the spleen, and there is mechanism to protect the eye, and it's called the anterior chamber associated immune deviation. So what it shows is there are different mechanisms to protect your eye from an inflammatory response. Sapna has already introduced to you different uveitic diseases. And mainly the uveitis is caused by retina-specific T lymphocytes. So here I am going to focus my attention on non-infectious uveitis, that is sterile uveitis, not that is caused by infectious agents. So they are mainly caused by T lymphocytes that are specific to the retinal antigens. And therefore, we can call it as an autoimmune disease because the response is to an autoantigen or a self-antigen and is not infectious. So whatever is the etiology, there is responses to the retinal antigens released from the tissue breakdown in uveitis patients. So the mechanism of the disease, we can, yes.
So what are the retinal antigens that provoke the inflammation?
Okay, so I had a slide with a long list of all the antigens that are present in the eye. Majority of the time, it is retinal arrestin in patients that we can see the patients respond to retinal arrestin, which is in large quantity. And another protein is a interretinoid photoreceptor binding protein, which is the one that we use in animals to induce the disease. The reason is most of the strains of mice, they are not susceptible to retinal arrestin. So the animal model is called the experimental autoimmune uveitis. Until 1988, when Dr. Caspi developed the mouse model for the uveitis, work was done in rats and monkeys. But since mice are easy to manipulate and we have several genetic models of, in mice strains, currently all the uveitic research is being done in mouse models. So here we induce the disease with an uveitogenic antigen, which is called the IRBP or interretinoid binding protein. But in some strains that are genetically modified, we can use retinal arrestin, which is the antigen that uveitis patients respond to. As I talk a little bit about the mechanism of the disease, you will know that the retinal antigens are sequestrated behind the retinal barrier, and it is not exposed to the immune system. Therefore, a naive animal will not develop a disease unless we immunize the mice with the retinal protein. Because of this immunization or induction of the disease, we can either induce a Th1 or a Th17 response. And this is more to do with what kind of cytokines are produced by the T cells. Depending on the antigen, how it is induced, how the disease is developing, there can be one particular type of cytokine dominating over the other. In the animal model, the beta NR3 strain is the most susceptible, and this is what most of us use. But the most commonly used inbred strain, which is the C57 black 6, is only moderately susceptible to the uveitis induction. But we are forced to use C57 black 6 strain sometimes because most of the gene knockout animals are present in the C57 black 6 background. And on the other hand, BALB-C strain of mice, which has more of a Th2 kind of a cytokine profile, they are protected from the disease. They are resistant to uveitis. So some basic knowledge about the autoimmunity. There are millions of proteins in our body. And why our own self, the T cells in the body does not recognize those proteins and attack them as a foreign antigen. So this is because a small portion of this antigen is expressed in our thymus, and the T cells are educated not to respond to your own self antigens. So that's called a central tolerance. The T cells are educated or tolerized against your own self antigen. But sometimes there is this imbalance in this tolerance, and some of the T cells can escape this education or central tolerance. And because of the differences in the level of expression of the protein in the thymus, once they escape and reach the periphery, for some reason they can get activated, either because of a mimicry to a microbial antigen, or there is a leakage of the retinal proteins because of a damage to the eye. And the cells that are in the periphery can get activated, and they find their way into the eye through circulation. Once they find their specific cognate antigen in the eye, they start proliferating and attacking the retina.
So in general, there is susceptibility to autoimmune disease, and women are more susceptible. Does it also apply for the retina as well?
Yes. So most of the autoimmune diseases are regulated by your MHC molecule. In human, it is called the HLA molecule. And that is true with most of the inflammatory diseases. It's because MHC molecule is the one that is presenting the antigen to the T cells. So certain MHC molecules can present certain pathogenic moiety of the antigen, and certain HLA molecules cannot present that pathogenic moiety. So some people are protected or resistant to the disease, whereas others are susceptible to the disease, depending on what HLA molecule that you have. So we can explain a little bit more in detail later. So here, the uveitogenic T cells that are present in the periphery gets activated because they have escaped the central tolerance mechanism, and they use certain homing molecules, migrate into the eye through the blood circulation, and see their cognate antigen in the retina, and start proliferating in the retina and causing the inflammation. So it's very intriguing how does the first cell, T cell, get into the eye? Okay, there has to be some prerequisites and some predetermining conditions that allow this to happen. So earlier, when radioactive labeled T cells were put into the eye, into the animal model, we have found that if you put 10 million radio-labeled eye-specific cells into the animal, 150 of them reaches the eye. But we can induce a disease with as few as 0.5 million cells. If you transfer 0.5 million cells, we can induce disease. That means you only need an approximately 7.5 cells to cause the disease. If the number of cells reaching the eye is that few, if you transfer only 0.5 million cells systemically, and if you have 7.5 cells, it can still cause the disease. So T cells are activated by chance in the periphery. Like I explained before, they can encounter the retinal antigen that is leaked out due to trauma in the eye, or they can find some kind of microbial mimicry. They proliferate, they travel to the eye, and then they recognize their specific antigen in the eye, and that causes more proliferation and release of inflammatory cytokines, which will recruit even more cells into the eye to cause the inflammation. So unlike the naive T cells, the antigen experienced cells escape the immune privilege. So if your cells are not activated in the periphery, the ocular immune privilege is working. But if somehow the cells are activated in the periphery, then the ocular immune privilege does not work. So it cannot control or regulate the activated retina-specific T cells. We have shown this in our animal model, where if you can deplete the regulatory T cells in an already sick mouse, so we are inducing the disease in the mouse, and at the peak of the disease, if you deplete all the T regulatory cells, you can get a higher disease, which means that there are regulatory cells circulating in your body that is keeping the disease under check. But sometimes there is a remission of the disease, and during that time, if you deplete the T regulatory cells, it can exacerbate the disease also. So this experiment tells us that there are T regulatory cells circulating in the body, which is suppressing the inflammatory response.
So this compartment of the retina, it is accessible by the circulating.
So once the damage is done, once the inflammation is there, the vessels are broken, there are sometimes leakage of the blood into the eye, that blood retinal barrier is lost. And then there is continuous circulation of cells with the systemic part. There's work done by Dr. Iguagu's group also shows that there are B cells that are regulatory cells, which can induce T cells that are regulatory. So it's not just the T regulatory cells or the T cells that are playing a role in uveitis. There are also B cells that plays a role in the uveitis. So to summarize the first part, how the disease is happening, there is always a retina-specific T cell circulating in your body that has escaped from the thymus, that are not tolerized at the thymic level. And this is because of ignorance. When there is not enough expression of the retinal antigen, the cells have escaped the tolerance, and they go circulate in the periphery and are getting activated outside the eye, because the eye is still, the retinal antigens are still in a sequestrated condition. But the cells somehow, when they are trafficking in the periphery, gets activated. Once it gets activated, the activated T cells can actually cross the blood-retinal barrier because they are not naive or dormant state. They are activated. And they will squeeze through, escape the blood-retinal barrier. And once they reach the eye, they will find its specific antigen in the eye, which is either retinal arrestin or IRBP, which is the retinal binding protein. And once the T cells come in contact with the antigen, which is actually presented by the antigen presenting cells that are present in the eye, like microglial cells, Muller cells. These are cells that can present the antigen to the T cells. And once the T cells comes in contact with the antigen presented by the MHC molecule on the antigen presenting cells, that T cells gets the signal to activate and proliferate. And those effector T cells are resistant to the inhibitory local environment in the eye. Though you have a lot of TGF-beta and other immunosuppressive molecules in the eye, the effector T cells escape that inhibition. And then they induce a uveitis, and they circulate into the system. But in the system, you have certain T regulatory cells present. If you have less number of T regulatory cells, your T effector cells will take upper hand. So it depends on how many T regulatory cells are circulating or how many are generated to suppress this effector T cells or the pathogenic T cells. That will, the balance of these two cells will tell you whether you will have a disease or whether you are under remission.
It will use steroids.
So steroids are not specifically suppressing any particular T cells. It's bringing your whole immune system down, under check. So animal models have often helped us to predict what's going to happen in the human system. And most of these drugs have been tried in the animal model before putting into the phase 1 or phase 2 trials. So as I explained before, we don't have a single animal model that can exactly mimic the human system. But in the human system itself, uveitis is kind of like a syndrome. There is no single clinical form for the uveitis. You heard Sapna talk about multiple different forms of uveitis. So these are the models that we have developed in our laboratory. So a normal retina, mouse retina, will look like this with no infiltration. And this is the classical EAU, or the experimentally induced uveitis model, where we are injecting the retinal antigen into the mouse to induce the disease. This is injected along with bacterial antigens like Mycobacterium tuberculosis. We can also induce a disease if we are loading the dendritic cells with the retinal antigens in vitro in the tissue culture room, and then transferring the dendritic cells loaded with the antigen into the mouse, we can induce the disease. It doesn't have to be directly into the eye. We can inject systemically, and the T cells are specific to the retinal antigens are always circulating. They will see these dendritic cells that are already loaded with the antigen, and that can stimulate the T cells and it can go into the eye. There are two spontaneously developing uveitis models. This model, which is on a air knockout mice. So air is an antigen or a protein that is required for the expression of self-antigens in the thymus. So it's not just specific to uveitis disease. If the mouse does not have air protein, then there is no expression of a self-antigens like insulin or collagen or myelin. Self-antigens are absent in the thymus. Therefore, your T cells does not undergo education, thymic education to tolerize themselves. So the T cells are very active in these air knockout mice. So most of the T cells are so-called pathogenic T cells, that the moment they encounter the antigen, they become very vicious and cause the disease. So in the air knockout mice, they normally develop uveitis and other autoimmune diseases because the self-antigens are not expressed in the thymus. We developed another spontaneous model. In this model, this is a genetically manipulated mouse. What we have done is we have cloned the T cell receptor specific for the retinal antigen and engineered the mouse to express this specific T cell receptor. So in most of the T cells in this particular strain of mice are specific to the retina. And in these animals, the uveitis develop even before the pups are weaned from their mother. So even when they are very, very young, they already are born with the uveitis. We'll explain more about that model later. So far we have three different types of uveitis model. One is induced in the naive animal. So the naive animal normally don't have disease, but we have to inject the mice with the retinal antigen along with a bacterial component, or we have to provide the mouse with an antigen-loaded dendritic cells to induce the disease. The other model is the spontaneous model where we are not inducing any disease, but the animal is genetically modified either to express the retinal T cell receptor or it lacks the air protein. And in both cases, the animal develops the uveitis by itself without any manipulation. Another model is, this is what we use usually to mimic the clinical situation. In this case, the uveitogenic T cells are generated outside in naive animals by immunization, and the T cells are isolated from these mouse and then adaptively transfer these uveitogenic or the pathogenic T cells into naive animals, and they develop the disease. So this clearly shows that a T cell can mediate the disease. We don't need any other component. If you have pathogenic T cells, pure T cells, if you transfer into the naive animal, those pure T cells that is specific to the retinal antigen can cause the disease. So the first model, the classical EAU model, I already explained, where we are immunizing the mice with complete Fruins adjuvant that has Mycobacterium tuberculosis, heat inactivated. And by day 9 or day 8, day 9, we start seeing signs of inflammation in the eye. So we look at the eye of the mouse under a fundoscope, and we can score the disease just like how Sapna had explained to you the scores depending on the amount of cells that are infiltrated into the eye and the damage that has happened into the posterior aspect of the retina. By day 12 to 14, the disease peaks. That's maximum inflammation. And then slowly it leaves the scar behind, and the active inflammation starts subsiding. So you can see that in a naive animal, the retinal layers are intact. So this is the photoreceptor layer. Whereas when we induce the disease, the photoreceptor layer is the continuity is lost. There is inflammatory exudate below the photoreceptor layer. There are lots of inflammatory cells that are infiltrated into the retina. And this is a model that has been used in the past 28 years. And it helped unravel many basic mechanisms of the disease and to develop treatments for uveitis. Another model, which is also an induced model, which is a humanized model. So like I explained to you earlier about the HLA molecule, we have created HLA transgenic mice. So these mice lack the mouse MHC molecule. Instead, they have human MHC molecule, so that we can now look at what is the antigen actually presented in a human system to the human T cell. Because when we study the classical EAU model in the mouse system, it is the mouse-specific MHC molecule presenting the antigen specific to the mouse T cell. But it may not be the same pathogenic moiety that is presented in a human system. So in order to understand that, we developed different HLA transgenic mice with different HLA molecules. And you can see that certain HLA molecules do not present pathogenic T cells, or they are resistant to the disease. Whereas some of them, if you have an HLA DR3 or HLA DR40402, you can get very severe uveitis. This is because these MHC molecules can recognize the most uveitogenic segment of the retinal arrestin, present it to the T cells to cause the disease. The advantage of this model is you can induce a disease with the retinal arrestin, which is exactly the same antigen that the patients have the response to. It's not the IRBP. In the regular normal inbred mice, we can induce the disease only with the IRBP, because the mouse MHC molecule cannot recognize retinal arrestin that is seen by the human system. So the second model is the dendritic cells that are pulsed with the antigen outside the body and then transferred into the animal's body. And the T cells in the animal's body will recognize these dendritic cells that are presented with the retinal antigen. This has a different clinical feature. You can see the lesions are more punctate, and the infiltration is mostly neutrophils, not the T cells. And this is also more predominantly interferon gamma mediated, that if you induce the disease in an interferon gamma knockout mice, the animals do not get the disease. The adaptively transferred model, where effector T cells are primed outside the animal, the recipient animals, and the recipient animals are transferred with the uveitogenic T cells, and the cells alone can cause the disease. And this is more clinically relevant, because in the human, we are not inducing the disease with any bacterial component or a CFA. So we can look at the effector phase of the disease. That's when the patients are coming to us, when the initial induction of the disease has already occurred in the patients, and we are presented with a clinical case where there are T cells already in the eye. And so this is the model that is more relevant if you want to study the effect of any therapeutic drugs, like a treatment strategy. So like we explained, uveitis is a paradox, right? We know that the T cells has to get activated outside the body in order to reach the eye. The T cells in the periphery is not seeing the retinal antigen. The antigens inside the retina is sequestered. So how are these T cells in the periphery getting activated? So the first activation, how is it happening? This is the question. Based on a lot of evidence from different uveitis models, there is an component of bacterial stimulation in some of these uveitis models. You can see that Klebsiella infection is involved in a HLA B27 associated ankylosing spondylitis disease, or some gram-negative bacteria is involved in reactive arthritis, and streptococcal infection in Behçet's disease, and mycobacterial infection in sarcoidosis. So we can assume that some kind of microbial stimulation is happening to the uveitic specific T cells in the periphery, and then later, because of a mimicry to the retinal antigen, those T cells find its cognate antigen in the eye and is attacking the retina. So this is the spontaneous model that we have developed in our lab, where we have immunized the mice to induce the disease, isolated their T cells that are pathogenic, and identified the T cell receptor that is specific to the pathogenic epitope or the pathogenic moiety of the antigen. We have cloned that receptor and put it back into a naive animal. And so these mice now specifically express the T cells receptor that are specific to the retinal antigen. So they have a higher frequency of T cells that can recognize the antigen than a regular unmanipulated inbred mouse strain. And because of this higher frequency of pathogenic T cells in them, they develop the spontaneous disease. And what we have seen is, like I explained to you, these mice develop disease as early as the weaning age, even earlier than the weaning age. And what we have done is, we treated these mice with an antibiotic cocktail. So AMNV stands for ampicillin, metronidazole, neomycin, and vancomycin combination. So we provided them with this antibiotic cocktail in their drinking water. And when they are kept under this antibiotic umbrella, their uveitis is, the severity of the uveitis reduced. We can also develop germ-free mice in micro-isolators that they are not exposed to the outside. They don't have the same commensal bacteria that we have in the gut in the normal mouse. They are mostly 99% free of the gut bacteria. And you can see that in the germ-free mice, they don't develop the spontaneous disease. So these are mice that possess T cell receptors specific to the retinal antigen in large frequency, in higher frequency. But just because we removed the bacterial component in the gut, in the germ-free mice, there is absence of bacteria everywhere. But in the AMNV treated mice, we have removed it from the gut, and the severity of the disease is less. But if we bring the germ-free mice outside, expose them to the commensal bacteria by co-housing them together with the regular SPF mice, they get the disease back to full severity. So this shows that there is a role for the bacteria, either in the entire system or in the gut, that is mimicking like the retinal antigen and can stimulate the retina-specific T cells in the gut. And then when it traffics into the eye, see the cognate antigen in the eye and cause the disease. So gut harbors 100 trillion bacteria, and it has a very large surface area. It's a major reservoir for lymphocytes. So in the periphery, when the retina-specific T cells are circulating, it's also reaching the gut, where we have trillions of bacteria. We have shown that in the gut of this genetically manipulated mice that has the higher frequency of retinal antigen, we are showing here a TCR signal. So let me explain to you what the SAP70 is. A molecule that gets phosphorylated when the T cell receptor gets activated. And we have created a mice that will glow green fluorescence whenever the SAP70 molecule is activated. Okay. So what we are showing here is the T cells in the gut that are glowing green fluorescence, and also showing the red color, which is specific to the T cells, okay, CD4 T cells. And so if you have a green and a red together, that shows the yellow fluorescence, which means that the T cells specific to the retinal antigens are getting activated in the gut of these mice that are genetically manipulated to express retina-specific T cells. So this is specifically showing that they are getting activated in the gut. The antibiotic treatment shows that there is a role for the bacterial population in the gut. So we think that there is a molecular mimicry for the retinal antigen in the commensal bacteria that is harboring the gut. So there is a role for the gut flora in inducing uveitis disease. So the conclusion from our animal models are there are different types of T cells that can cause the disease. It can be either Th17 cells, which produces more of IL-17 kind of pro-inflammatory cytokines. And those are generated whenever we are inducing the disease with bacterial components, either in the spontaneous model where the gut microflora is involved, or in the CFA immunization model where Mycobacterium tuberculosis is included. Or it can be a Th1 driven disease, where also in the spontaneous model that you see that there is more Th1 driven response, or in the adaptively transferred cells where it's more Th1 driven. So it explains the heterogeneity of disease in the human. There is in the human disease condition, you can have either Th1 dominance or Th17 dominance. And it depends on what is the inductive mechanism, what causes the disease to begin with. And this is important to know which cells to target for therapy. Sometimes targeting Th1 can exacerbate the disease, or targeting Th17 exacerbate the disease by Th1. So in each individual, how the disease was induced could be different, and the targeting, the therapy, targeting which cells is very important. So the results that I showed here is a combined effort from several postdocs from the past. Dr. Caspi is my mentor, and she's the one who developed the mouse model of uveitis in 1988. We have several collaborators, both inside our institute, outside our institute, several pharmaceutical companies that are involved. And we take advantage of all the core facilities that we have to do different complicated techniques. Thank you for your attention. I can take questions if you have.
Thank you very much. That was really spectacular.
Thank you.
Wonderful. Very good. So do we have some questions? Yes.
So the question I have is, I think one of the experiments you showed that you could have uveitis early on. I don't know whether you were referring to embryonic stage of the rat or mouse, or, but the question that I have is, could you see that also happening in early on in children in humans?
So this is a genetically manipulated model, but Sapna will be able to tell if children.
May I borrow that? Thank you. We've seen toxoplasmosis in children, they're born with it. Also, you can have viral infections, so people are born with it affecting the eyes. But most of the other diseases we see are adult or after birth.
I could one follow. So if they are born with it, then is it possible that over time they can, they are treated or they recover, or is it going to continue on to their lives?
100% sure of, which is toxoplasmosis, and I'm really sure they could be born with it. They get treated, but they stabilize. And there are some that we see them with it, so we know they were born with it, but now it's not affecting them, so it's self-resolved.
Yeah, in the mouse model, we have not looked at the embryonic stage. The earliest that we can look into the eye to see whether there is inflammation is only when the mouse eyes opens up, because they are born closed. We haven't done a histology. We could take a histology of the newborn and see whether they have. And the incidence is not 100% because different individual mouse develops the disease at different stages. It's not like an induced model where every animal develops at the same time. It's not like a synchronized fashion. Some develop early, some develop a little later.
Yeah. I think it's fascinating that in that sort of incomplete list of associated diseases with uveitis, many of them autoimmune in nature, the current emphasis and focus in each of them is toward the microbiome and the role in mediating innate and adaptive immunity. And in that context, what you've described so elegantly would seem to fit in to that broader picture, although there are many links
so it's
that
not
have to be made.
specific to uveitis. We have seen this in many autoimmune diseases, the microbial component. And in some cases, they had been successful in isolating the molecular mimicry with a bacterial cell wall protein or something like that. We are still investigating what could be the reason. We are trying to find out a region of any bacterial protein that has a mimicry with the retinal antigen bioinformatically. And then when we try to induce the disease with that bacterial protein, we have not been successful to recreate uveitis with that bacterial protein. We are still investigating on that.
Well, thank you, really, both of you, very, very much. That was one.
So, if you have to look at the lymphocyte count, are you looking in the blood or in the eye by the fundus imaging? Sapna mentioned that you could count the number of cells.
Yeah, so what we are doing is we can collect the eye tissue, smash it up and isolate the T cells, and then we stain it for antibodies, surface antibodies to T cells, and looking at under the fluorescent site.
So in the clinical studies, Th17 is generating interleukin 17 is one of the primary inflammatory cytokines.
So also Th1, interferon gamma producing cells too. But in different patients, you see at different levels, there is an imbalance between them. What we have seen in using the animal model is if we knock out interferon gamma, mice that don't have interferon gamma, there is still uveitis, even more severe than the regular wild type animal, which shows there may be in IL-17 that is causing the disease. But when we knocked out IL-17, still we get the disease. So now we have a double knockout, which lacks both interferon gamma and IL-17, and still we see disease developing. So our lab is now investigating what is the third molecule that is causing the disease.
Right, well, thank you very, very much. Thank you. Next week, the topic is Alzheimer's disease.
Thank you.